Do you want to start?
Yes.
All right. All right, folks. Thanks for giving us the opportunity here. So today we're going to talk about live donor liver transplant, which hopefully comes to us in the next couple months. We're evaluating donors and recipients. Now we actually Ross and I just saw a donor this morning. And so hopefully in the next couple of months, we'll do our first live donor liver transplant. And so I think this is opportune. Yeah, we're good.
Rolling in.
Yeah. Close the door. Absolutely. All right, so let's see here. So we always start these talks with the reality of transplantation, which continues to this day, in that we have a supply-demand issue across all organs, and liver is no exception. We still have an organ shortage, so roughly about 9,000 liver transplants occur in the United States every year, and the vast majority are deceased donors. You want to let that person in?
Yeah.
Okay. This is going to be fun. Do we want to wait?
If anyone's coming in, it's more
Cool.
people that are just giving report and stuff.
Oh, yeah, it's cool. While we wait. Hey, how are you?
Okay.
Hey, like one of those like toys. All right, so yeah, so the vast majority are deceased donors. You guys are all seeing them. We're doing more and more transplants. We're trying our best to transplant patients as aggressively as possible with organs that honestly, a few years ago, we wouldn't have used. Hepatitis C, we have a cure for Hep C, so we use Hep C positive organs. We are now using machine perfusion. So the last couple of cases we've done are livers that were on a pump for 16, 17 hours before they were transplanted. And so we're doing our best to kind of increase the deceased donor supply. That being said, we still have about 20% mortality on the wait list. That's either patients that get that die unfortunately, or get delisted because they're too sick. And you guys see that unfortunately too regularly in your units. So that's the.
Is everybody online hearing?
Just message me.
Yes, we can hear you.
Yeah.
We can hear you well. Thank you.
Yes, I can hear.
Challenge, and that's where living donation comes in. Right now, only about 500 to 600 live donor transplants happen yearly across the United States, and so there's a lot of potential, I think, to increase. All right, next slide. Let's see what we got. Okay, so the advantages of live donor liver transplant, and there's a bunch of them, right? But it's a little counterintuitive because people think the advantage is, it's simpler, or it's a healthy donor, it's elective, all that stuff. And that's true, but the reality is actually live donor is more complicated, right? You have to take a healthy donor, split their liver, they're getting a partial liver, everything's smaller. So the reality, it's actually not as good in that sense. The reason why it's beneficial is that it gets patients transplanted sooner. Right, so those folks that have a lower MELD score, they still have a risk of death, right? And we often see patients that have a MELD score of 15, 18, 20, and then all of a sudden something bad happens. They get an infection, they bleed, they fall and break something, and all of a sudden their MELD's 35, and we can't get them transplanted sooner or in time. So there is a risk of death at lower MELDs, and the advantage for a live donor is it gets you off the list and transplanted quicker, and that's been shown to improve. If you look at patients that waited on the list and then got a deceased donor versus patients that got a live donor, the live donor people do better. So I think that's the take home with this slide. All right, so, who can be a living donor? It's actually pretty broad. This is actually a recipient. Yeah, this is a recipient who can be able to receive, yeah. So basically, anybody who's listed for a deceased donor can essentially get a living donor. That being said, the sicker you are, kind of the less sweet it is, right? Because the sicker you are, the more stress you're going to put on that partial liver. The more severe your portal hypertension, the worse your ascites. You need, as your MELD gets over 30, you really need a whole graft that's really going to, kick in right away, and that's the most ideal. And the reality is, in the States, if your MELD's over 30, you guys have all seen it, you get transplanted pretty quickly. So it's if you're listed and your MELD score is teens to mid-20s, that's where you're really stuck from a deceased donor standpoint, and that's where living donation is beneficial to you. Okay, so who can be a living donor? And obviously the criteria are pretty strict. You basically have to be healthy between the ages of 18 and 60. Now, as donors get over 55, we're very picky, obviously, and you have to be in really good shape and not have a lot of comorbid illness. I think that the list is self-explanatory. I think if you're between 18 and 60, you're healthy. You go through a rigorous workup, as I think some of the slides will show, and and it's not just your age and your health, but as we'll see also, it's the anatomy, and we're all built differently. Right? Our livers are all different. It's not like it's a, 1995 Honda Accord. You open the hood and no matter which one you open, it's all going to be the same. We're all different. And when we're dealing with deceased donor, it kind of doesn't matter. We don't really care what's on the inside because all the stuff we're sewing to is on the outside. We're taking the whole thing. But when it comes to living donors, what our anatomy is inside our livers is critical because we have to split that liver and keep the donor side safe and keep that donor safe, but also at the same time ensure that that graft we're using is a graft that's going to do well in the recipient. So that's kind of an added part of things that also is more complex with live donors. All right. So eval, just briefly, we've got a great live donor team that works kind of hand in hand with the recipient team. With a similar structure, with a couple different differences. It's obviously a multi-D team. We've got surgeons, hepatologists, we've got coordinators. You've got it there: pharmacy, social work, dietary, and then whoever else is needed. And then most specifically, and we'll talk about it, there's a living donor advocate, which is critical too when it comes to, you're pushing me along, eh? Okay, no problem. To living donation. And the live donor advocate is very important, not just for liver, but for any form of living donor, including kidney as well. We have a donor team, we have a recipient team, we have family members donating to each other or strangers donating to each other. And the living donor advocate really ensures that everything is being done above board, that specifically advocates for the donor, to make sure that the donor's needs are being met, to make sure that there's no coercion, to make sure that the donor is aware of the risks. And honestly, the function of the ILDA, aside from that, is to keep the team in check, to make sure that the team is acting appropriately and always serving the best interests of the donor. And obviously we all want, including the donor, we want a good outcome for the recipient. But the critical fact is we need our donors to stay safe and not be coerced in any way. So this role is very important and it's kind of unique to living donation. Okay. So what do we got here? Looks like, okay, so there's two different types of donor, basically, of donor graft. Is a right lobe or a left lobe? And, how much liver you need depends on how much you weigh and how sick you are. So, there's all sorts of formulas we have to kind of calculate that. But Basically, that's the bottom line. Now, if there's somebody who's donating to, a child or a man donating to a much smaller woman, we can often use the left lobe. The reality is most adult to adult liver transplants that happen across the country are right lobes. So they're, a right lobe being donated to an adult. And we'll go through kind of the steps of the operation, but basically that's the case. And oftentimes donors ask what happens to the gallbladder. The gallbladder always gets resected during the operation. So at the end of the day, nobody has a gallbladder. The gallbladder for the recipient comes out with the liver, and the donor's gallbladder gets removed as one of the first steps of the operation. So why can we do this? How come, people can donate a part of their liver? Well, because the liver grows back, which is pretty wild. A healthy liver, you can resect 70 to 75% of someone's liver. And if that remaining 25, 30% is healthy, it will regenerate very quickly. And, the other reason we can do this is we've gotten we have a lot of knowledge about the anatomy of the liver and how it's divided. And most of us know that the liver is divided into 8 segments. And all those segments have unique blood supply, essentially. And so if you're in the right plane, you can split a liver into segments, in a way that keeps that segment functional. And that's the key. So if you're splitting a liver down the middle, for example, you are keeping the right lobe with segments, 5, 6, 7, 8. The left lobe has segments 1, 2, 3, 4. If you do it correctly and the anatomy is appropriate, both those lobes should continue to function, with a blood supply, with a biliary drainage, just as well as if they weren't split. So that kind of knowledge of regeneration and kind of next level knowledge of liver resection allows us to do live donors safely.
Does it regenerate to 100% of its original size?
Like 98% or something like that within 6 weeks. Pretty crazy. And in fact, a lot of the regeneration happens in that first week or two, and then it really slows down. So in fact, if you stayed in the OR long enough, you could probably watch the liver grow. And if you notice, as we're checking labs every day and you see that FOS go from 5 to 2, what's happening is those hepatocytes are multiplying and sopping up all that FOS. And that's why we're always, what's the FOS and more FOS? Because we know that that liver is regenerating very briskly. And then if you notice, like day 4 or 5, that FOS all of a sudden stops dropping or drops much slower. And that's because, again, that liver is really, revved up. And why that is because, the liver gets portal flow. And all of a sudden, that left lobe lost its buddy on the right. And that portal flow is saying, hey, man, I need more, to metabolize and to digest my food. And there's growth factors going to that liver. And it's pretty wild that the human body can kind of adapt its physiology to what's needed. And the liver grows, but it grows very quickly. Now, people ask, obviously, oh, it grows back. So great. Can I just keep donating, my right lobe? Good question. But the reality is you never get that right lobe back. Right. And so if you donate your right lobe, you're never going to have all that anatomy's gone. Right. The right portal's gone. The right artery's gone. The right hepatic vein's gone. The bile ducts are gone. It's just the left lobe has grown in size. And so once you donate, that's it, whether that's your right or your left. And so once it's over, the donor has a left lobe and the recipient has a right lobe, and combined they have a whole liver. But the reality is you just have one or the other.
Is there a risk that it won't grow back?
Yep, there's a risk. Thankfully, it's low because we're OCD about the workup. So so you can't just take out as much as you want, right? And so there's a minimum remnant liver that a donor needs to keep, and that's 30%. There's a reason why it's 30%, because below 30%, your risk of either kind of slow liver growth or liver failure goes up. And we know that from resections, right? People that have tumors in their livers that don't have the luxury of keeping 70%, 30%, we go down to 25, 20. And oftentimes you can go to 25% and it's okay, but no question, the risk of liver failure goes up as you go below 30. So any donor that has a remnant liver that's less than 30 gets declined, really across the country, for that reason. Now, if you go into liver failure as a donor, thankfully these days that's very rare. You obviously would likely require a liver transplant to survive. Okay, and so that's how we figure that out. So basically, so we take our CT scan, we take our MRI, and we basically anonymize it so they don't know who it is, and then we send it off to a private company that basically analyzes the liver and tells us, okay, left lobe in green, that's how big it is. Right lobe in pink, that's how big it is. In this example, these are hepatic veins up there. It tells us exactly where we're going to cut and what veins we're going to cut across during the surgery. And then we can assess how big of a piece we're leaving behind, how big of a piece we're taking out, and whether those veins, those like little purple and pink deals, need to be reconstructed before we transplant the liver so it works well. So we really go to the OR kind of knowing not wanting any surprises with the anatomy. And I think that's obviously very critical when it comes to this type of surgery. So what happens here before the donor gets to you guys, before the patients get to you guys? The patients come in the day before, both of them, and they get tucked in. We get consent. Anesthesia sees them, make sure there's no last minute glitches, last minute blood work, any issues. And the next morning, the donor goes to the OR first. Go to sleep. We do all the usual ABO stuff. Donor gets a central line and an A line. And also before they go to sleep, they get an epidural. Well, not an epidural, a spinal shot, like a Duramorph shot. And that takes them through surgery and then lasts probably 8 to 12 hours post-op. So they're relatively comfortable post-op. Then we open up, we take out the donor's gallbladder, we shoot a cholangiogram to make sure that the bile ducts are as advertised on the MRI. And then once we are happy that the donor's safe and that we're going to proceed, the recipient goes to the OR next door, goes to sleep, and then the usual lines that you've all seen with a recipient go in. The lines in the neck, the A lines, all of that stuff is the same. And then the recipient's hepatectomy starts. The team starts to take out the recipient's old liver while the donor's liver is getting split. And once we're happy that the recipient is safe and that old liver is going to come out safely without any issue, then the remaining last connections get cut, and that liver graft comes out, gets flushed on the back table so it doesn't clot, gets cooled down so it doesn't get injured, gets any vein reconstructions that need to happen, and then goes to the recipient room and gets transplanted. And then the donor gets closed up, it's all good, there's no bleeding, we're all happy, and gets extubated in the OR almost always, and then comes up to the unit. So the donor comes up to the unit, about 1 or 2 o'clock in the afternoon, but then we got to do the transplant, right? So then the recipient needs another probably 4 hours. So the recipient comes up here about 6 o'clock at night, usually intubated, and they start their recovery. What we got? Okay. So what kind of risks do we have here? And these are donor risks, although they can be applied to the recipient somewhat. These are donor risks. Bleeding, obviously, we're super concerned about bleeding, although it's minimized significantly with the use of transection devices that are pretty fancy, and we take our time and we use cell saver, so we give back any blood that bleeds. But nonetheless, the risk of bleeding is there, and the risk of bleeding extends probably about 24, 48 hours post-op, and that's why another reason why the patient's in the unit, to make sure that there's no acute bleeding that happens. They have a drain, so if there's, aside from blood work, you have a drain to look at. You asked the question about liver failure, that can happen, so we're monitoring the labs closely and the patient's mental status, and INR, to make sure that that liver is doing what it needs to be doing. Stricture is a long-term risk. We don't have to dwell on that, but I think in the hospital, bile leak is probably the biggest risk, purely from the resection. The patient's going to have a bile leak, and another reason why we leave a drain in. Anesthesia side effects like any operation. Pain obviously is a big thing with donors. Many donors never had an operation, let alone a big abdominal operation. So it is a big deal. And you know what you'll find is actually the donor for the first couple days is, you know, like just got hit by a truck. You know, they're like, what the hell just happened to me? But the recipient just got a liver transplant and they feel great and they got steroids and they have no pain. So the donor's like, hey man, what's the deal? Yeah. But that quickly reverses, and obviously after the first couple of days, the pain's better, the donor's recovering, and obviously they do very well. But the first couple of days, you know, definitely the donor needs a lot of TLC, and you got to make sure that their pain is well controlled and you know, that they're comfortable. So a couple of days in the unit, and then they come down to the floor. You know, so I don't know how much we want to dwell on these pathways. They're certainly there. Just briefly, by the way, I don't know what administered pain is. We might want to fix that. Yeah, but bottom line is the donor stays in the hospital like 5 to 7 days. They're in the unit a couple days, maybe 24, 48 hours. And once we're happy that the donor's doing well, vital's good, pain's good, no bleeding, no issue, liver's happy, we come down to the floor. Recipient, you know, probably stays in the unit similar to our other recipients, you know, deceased donors. You know, when things are stable and they don't have any more ICU needs, down they go to the floor. Oh, yeah. So well, not ideally, but for sure it needs to happen. They have to have different teams. Colleen, is Colleen here?
Nurses.
Colleen?
It's on.
We
She's
talk
in.
different nurses, not the
Yeah, nursing teams.
nursing team, just separate nurses.
Absolutely. Got to have different nurses. I think the ratio, I think there's New York State laws about what the nursing ratio needs to be and all that kind of stuff, but I'm sure the unit has that covered. But definitely different nursing teams for the donor and the recipient, the way it should be.
Ratio, she said 1 to 4.
1 to 4. Perfect. And then here, you know, you got the pathways that are very detailed, but basically, you know, call it an enhanced pathway or whatever, but we basically have kind of a you know, obviously there's always deviations from the pathway, but there are, you know, certain goals that we try to meet every day when it comes to the donor and the recipient. Now, again, I think you guys have access to all of this stuff. Obviously, the key things we talked about, you know, we want to make sure pain is okay. There's obviously, you know, prophylaxis when it comes to antibiotics, when it comes to subQ heparin, when it comes to fluid resuscitation. You know, the donor has one drain. Donors generally do very well. And it's you know, after they get through that first 24 hours, it's pretty smooth sailing. But all that stuff's, you know, available to you. Same thing. I think this is just, you know. So 5 to 7 days in the hospital. What do we want to make sure? The pain's good. They're ambulating. They're eating. There's no infection. Their incision looks good. There's no pneumonia. You know, once all that's good and the patients, you know, their donors need, you know, 6 to 8 weeks to get all the way better. But usually after the first week, they're good enough to, you know, to start recovering at home as outpatients. So the recipient, I think it's good to just focus on a few things here. The main differences, we've all taken care of deceased donor recipients. The main differences is they, you know, and I think this is probably, we have that, yeah, next few slides, but it's a partial graft, so it does act a little differently. You know, it doesn't kick in quite as quickly. The INR drifts up. The bilirubin oftentimes rises, to semi-scary levels before it comes down. There's a biliary drain for every recipient that's hooked to gravity. That's also a main difference. We've moved away from biliary drains for recipients in recent years, except for living donors. So that drain sits in the bile ducts, and it's nice to have a kind of essentially a stent across the anastomosis, but also to be able to, anytime we want, shoot a cholangiogram and see what the bile ducts look like, especially when the bilirubin's 10 and you're scratching your head what's going on. It's nice to just shoot a cholangiogram and go, oh, great, the bile ducts look great. There's no issue. And, so that's why that's in. And usually about 8 weeks later, we just take that drain out in the clinic. It's not a big deal. 2 JPs usually instead of 3 in the recipient. And then whether they, depending on whether they have a roux or not, sometimes that NG tube stays in a bit longer. But really, those are the big differences between living donor and deceased. The other thing is actually just to, that I mentioned earlier, everything's smaller. All the connections are smaller, specifically the artery and the vein. And so the hepatic artery thrombosis rates are higher. So we really are always hyper vigilant about the artery. So we're getting ultrasounds at least daily. And if there's any concern, sometimes twice daily, to make sure that if there's any issue with that artery, we catch it soon so we can, go back and sort it out. Once an artery goes down, especially for any significant period of time, that graft is lost. And so we really try to be hyper vigilant about that. So you'll see we're going to give them a workout, from the standpoint of ultrasounds. What else we got? Okay, so we have enhanced recovery pathways, and I think those basically outline kind of, and we've tried to do this for all our transplants, not just living donors. So I think those are all going to get rolled out over the next few weeks to months. But we have one for living donation for both the donor and the recipient, and I think that's accessed on that website. So we got. Okay. So discharge, basically, I think all intuitive stuff. Make sure that the donor advocate is okay and available. Discharge instructions. They're going to see the surgeon and hepatologist, surgeon for a couple of visits, and then they'll follow up with the hepatologist. Make sure everything's okay at home. It's a big stress on families, especially, let's say a son donating to dad, you got the mom, who's the caregiver and who's helping, or many combinations of that, where it's very stressful on that one family member that's not in the operating room, right, that day, and in subsequent days caring for his or her family members. So we're mindful of that, and we have to support them as much as possible. Donor outpatient recovery. Yep. So liver grows back in about 6 weeks. You get the occasional cowboy that wants to go back to work quick, but generally, it takes a while, at least a month, if not 2 months, to get back to work. Even a desk job it's not fun to, sit in a chair at a desk, having just had surgery. So even desk jobs, they take some time, but in general, about 8 weeks, and that's usually enough. Obviously, the follow-up is thorough. And then, at the very least, after a year, the donors are followed yearly with labs. That's a New York State requirement. And then really after that, they follow with their primary care doctors. Same thing. This is I think these are brothers from about. These pictures are about a decade old now. They donated to this brother donated to his brother, PSC. Wonderful pair, and you can kind of see their evolution. It's remarkable how the patients bounce back and are healthy and gain weight and muscle and full of life a year later. That's kind of the follow-up. We'll see them closely early on, and then yearly after that. quickly about outcomes, because people always ask, and paper's a few years old, but I think it sums it up. The reality is there is I think the take home message with living donors from a liver standpoint, that's a little bit different from a kidney standpoint. You know, when we talk about kidney donation, we're always, harping on the chronic stuff over time that can affect your kidneys, right? Diabetes, high blood pressure, that sort of thing. The risks of the operation are there, but the operation's done thousands of times a year, and thankfully, the risks are relatively low with surgery. It's the long-term risk for kidney donation that we worry about, especially in younger donors. In liver donors, the risks are upfront, right? It's a big operation. We just talked about all the potential risks. When you look at a living donor long-term, and you compare them to normal, healthy people, quote unquote, and kidney donors, they live just as long and do just as well. So it's that, it's up to us to get them through that first couple of weeks. And if they do well, they're going to do well, the rest of their lives is the bottom line. And, there's a lot of questions about, can I have kids, and can I, play sports, and can I go skiing and all that stuff? And the answer is yes to all of this. They can just live normal, healthy lives. And we have data, not just from living donors, but from resection patients, who've had liver resections for many different reasons that date back, 40, 50, 60 years, and patients do very well after they heal up. Okay. Additional resources.